I'd like to welcome everyone to the VA section webinar today. Our topic is Suicide Prevention, a Community Effort, presented by Dr. Zachary Parrett. I'm Tiffany Fennell, Chair of the VA section of Division 18 and a psychologist at the VA Puget Sound Healthcare System. But before we begin with our presentation, I'd like to take a brief moment to mention that Division 18, Psychologists in Public Service, is hosting this webinar. Division 18 is made up of psychologists who serve in many public service settings, and we're represented by 6 sections of the division, including community and state hospitals, criminal justice, police and public safety, severe mental illness, Indian country, and veterans affairs. I'd like to highlight that Division 18 is the only division in APA that has a dedicated section for psychologists who work in the VA. And the division and section are highly active in working to build a community and network amongst VA psychologists. There are a lot of opportunities to be involved with Division 18 and VA section. So if you'd like to learn more about the division or join, please email me or find us on the web. We're also on Facebook and Twitter, and direct links can be found in the notes pod here in the webinar room. And one last note before introductions, all questions can be entered in the chat box, and Dr. Parrett will answer them towards the end of his presentation today. And if there are any technical difficulties, you can also enter those into the chat box as well, and I'll attend to those as quickly as I can. So now for introductions. Dr. Zachary Parrett earned his doctorate degree in clinical psychology in 2011 from the University of Indianapolis. He and I completed our internship at the same site, the Missouri Health Science Psychology Consortium, but unlike me, Dr. Parrett completed 2 postdocs, one in pediatric psychology and the other in neurorehabilitation. Following training, he worked in home-based primary care at the Eastern Kansas Healthcare System until November 2017, when he entered his current position as Kansas City VA's Suicide Prevention Coordinator. In his current role, he specializes in the assessment of risks for suicide amongst the veteran population, coordinates mental health care, and provides education and outreach to the Kansas City community regarding veteran suicide. Additionally, Dr. Parrett is a clinical assistant professor in the School of Medicine at the Kansas University Medical Center. So now I'll turn it over to our speaker.
Well, thank you, Dr. Fennell. Can you all hear me okay? Excellent. Hi, Shalisa. How are you doing? Welcome, everybody. Again, as Dr. Fennell said, I'm Zach Perrin, clinical psychologist and the suicide prevention coordinator at the Kansas City VA by way of the Eastern Kansas VA. And I see a couple of friendly names from that side of the state line. So hi all to folks that I know out there. And Brad up there in Minnesota, how you doing? No such credit needed for the postdocs, the multiple ones. I think enjoy being a poor post-grad student. So don't think it's any kudos, please. Hey, so my goal today, my hope today is to talk with you about veteran suicide, and specifically what the change and the wave forward is going to look like. I know a lot of you work at the VA. I would particularly love to hear those that are on the line that don't work for the VA. Where are you working at? What kind of facility are you in? And then maybe what is the relationship that you have with veterans and the VA in particular? I'd love to go back through those at some point today and maybe look at those and see where we all fit. Because very much what today is all about is the community effort for helping to prevent veteran suicide, patient suicide, and let's just be quite honest, human suicide. We can all kind of base it off of each other. But kind of let me go into this a little bit, that today my goal is to help represent the VA, particularly this Kansas City VA, and to be what I hope is one of the many caring voices, one of the many caring individuals that represent this kind of monumental effort of caring for our local veterans, our patients on a daily basis. I do want to talk straight with you today, directly, honestly, and sometimes uncomfortably, and I've given this talk before, and there was some uncomfortability to it too, but about the prevalence of suicide amongst our nation's veterans. It's a particular issue, no doubt about it. I'm going to share with you the state of affairs at the Kansas City VA, and maybe uncomfortably even more so to my leadership down the hill, but with full intent to demonstrate the openness that we, as health and wellness providers, I think need to have going forward. Share with you what these numbers are all about. But most importantly, most of all, I'm going to ask for your help. You signed on here for a reason. You're paying attention for a reason. And I hope you weren't planning on sitting back and just taking in information today, because I want you to be proactive. I want you to meet the VA. And if you're within the VA, I want you to meet those that are making the most effects. And if you're outside the VA, I want you to make the VA aware of what you can provide and how you can help. I want you to tell us what you can offer veterans, and in turn, what you need from the VA, what you need from us as community partners. And I want you to leave this presentation knowing that you do have a partner, and in fact, that we're not going to touch this rate of suicide and save the lives of veterans and patients that we serve every day without very much partnering in this better. All right, so full disclosure, I do not actually have any financial benefits or backings in any of this. I am speaking hopefully from the heart and from the mind, being as much of an expert as I possibly can. Here's what we're going to talk about today. We're going to talk about what the impact of suicide is here, but also what the impact is on your team, in your facility, in your state, and in your country at large. What the state of affairs in veteran suicide is all about, and then what the new national strategy is for preventing veteran suicide. I apologize. Cat out of the bag here, it is a public health approach. So if anybody's trained in that avenue of thinking, this is going to sound pretty familiar. I'll talk to you a little bit about, if you don't have a great idea about what my role is and what those that are in every single VA around the country that are called suicide prevention coordinators, what they do, talk about it and see how they can best be utilized by you. And then also talk about what this 2.0 version of suicide prevention is for the VA. And then I think that a slideshow of this is available for your keeping, which will have plenty of resources at the end if we get to thinking about things as we move forward. All right. So my big question to you today, and let's start the moment off in a somber way, but think about this. How many have you lost? Think of your agency. By a silent show of hands, who here comes from an agency or facility that has experienced, or which of you has personal connection with the loss of a veteran or a patient by suicide? I'm going to talk real clearly to you. I've lost 12. We've lost 12. The Kansas City VA has lost 12, and the Kansas City community has lost 12 veterans last calendar year alone that we know about. So I'm honest with you. How many have you lost? Countrywide, here's our number. Every single day. Current state of veteran affairs, 20.6 per the 2015 data report. 20.6 veterans every single day pass from their own hands, dying by suicide. And here's more of the problem. So let's admit it. We're not having the impact that we wanted, that we expected to have. This number, if you look at that graph, is at least stable, if not growing, year after year. And particularly the number of female veterans dying by suicide is certainly climbing. But I'm going to take a, let's see if that's working or not. Might not be able to see that just yet. All right, it might be on your PDF file if it opens, but let me tell you a little bit about what I'm looking at here. I have two graphs pulled up, and I apologize that it's not coming through on your side, but this is the veteran suicide data sheet for Kansas and the veteran suicide data sheet for Missouri. Every state that you all are in, this can be found and producible, and we can identify per your particular state what the numbers are. But let me at least tell you what I'm talking about here. Looking at more of the Kansas City area, and Kansas City is split on the state line between Missouri and Kansas. Yes, there is a Kansas City, Kansas, mostly Kansas City, Missouri, and that's where we're at. But here's a snapshot of Kansas and Missouri. In the state of Kansas, in 2015, there were 67 known veteran deaths by suicide. Okay, it's split up between the age ranges of about 35 to 54, 55 to 74, and 75 plus. So in Kansas, the suicide rate of 33.5 points is not statistically higher than the Midwestern or national rate. So Kansas is about where it is. Now, missing my visual impact here, but hopefully it's impactful just as much, I can tell you that Missouri is a different story. 180 total deaths by suicide in Missouri, with an overwhelming number as male and in the age group of 55 to 74. The rate of suicide for Missouri is at 39.3 points, and it's well above and statistically significantly higher than both the Midwestern and national rates. But if you could see my graph, you would see that the rate of death for those newly out of military service, death by suicide, those that are just transitioning or have just transitioned, is at an incredible rate of 71.4 points. And that's compared to Midwestern and national averages. And think about that. Why is that so much of a difference? Now, I think you can see this. So compare the number of veteran deaths by suicide to the general population of suicides. The numbers are even more staggering. There's an over threefold increase in ages of 18 to 34, and it's nearly double in all other age groups compared to other Missourians. And that gap grows even more when compared to Midwestern and national rates. Now, I didn't know about this when I took this position, and by no means am I throwing blame anywhere around us, but even just in one particular state, and I know that this is prevalent for many other states, we have a problem. And I've identified, and we have identified, that we have a problem in Kansas, we have a problem in Missouri, we have a problem in Kansas City, and we have a problem nationally. Let me take a step back. So where have we been? Let me go through a little bit of what the VA has been doing. Well, in 2001, the U.S. Surgeon General, the National Action for Alliance for Suicide Prevention, released this national strategy. This is where we started. Fast forward to 2007, we began this intensive effort to reduce suicide amongst vets because of a Public Law 110-110, the Joshua Omvig Veteran Suicide Prevention Act. I say that because one of the biggest things that came out of that act is the creation of the VA Suicide Hotline, which is now known as the Veterans Crisis Line. And it also established funding for people like me, suicide prevention coordinators at every VA, to specifically mandate that we are doing something about this and not just show, but to actually make responsibility happen. In 2008, we established a suicide surveillance system, clinical support system, to help identify and track reports of suicidal behaviors and suicide events. They also established a process for clinical review and flagging of patient records of veterans determined to be at high risk, as well as a protocol for how we're going to closely clinically monitor those folks during their period of high risk. Also in 2008, they developed and released the SAVE Suicide Prevention Gatekeeper Training. Some of you might have heard of that or been a part of that or actually even given that. I can tell you that every VA person on this call has been on an annual basis asked to be aware of what SAVE is. But it's also for non-clinical staff members as well. And additionally, the suicide risk management training for clinicians. 2010, they mandated outreach activities for us, in that suicide prevention folks can better engage communities with suicide prevention efforts, begin offering training on firearm safety through the VA Family Firearm Program, and help to kind of standardize suicide prevention nomenclature in conjunction with the Center for Disease Control and how we were talking about suicidality and suicidal behaviors. 2012, the VA implemented this significant program called the Behavioral Health Autopsy Program. And it's one of my significant roles in this idea that once a suicide completion occurs, we are asked to go back through the behavioral health record and digest everything and comb through everything and identify where we could have possibly had an effect. During phase one of this in 2012, we standardized chart reviews for vets whose deaths were known to their respective VAs or to the CBOCs that they were aware of. In 2016, the VA secretary made suicide prevention the top clinical priority for the VA. Think about that. Our biggest boss made suicide prevention our very top clinical priority, stretching over all services that we provide. Also in 2016, we released the most comprehensive study of veteran suicide ever conducted. And we began the rollout of ReachVet, which is of all of the 141 Veteran Health Administration sites, they receive information regarding, at that time, their top 8 veterans within their facility that represented their highest predictive suicide risk. Last a bit on this, but most recently, there's been a lot of work recently. In 2017, they added high-risk veterans metrics to the SAIL data, to our measurement improvement basis, and how VAs compare themselves with one another and compare themselves with community-based facilities. We also began further implementation of the ReachVet, and sites began to hear of the top 0.1% of the predicted risk within their facility. We implemented mandatory SAVE training for all those VA folk I was talking about, not only clinical staff, but non-VA clinical staff as well. 2017, they added 2 additional sites. My folks in eastern Kansas are well aware of this, that there was a brand new Veterans Crisis Line site added to Topeka just last year, I think, right? Yeah. So the Veterans and Military Crisis Line has significantly beefed up their ability to handle, which triples their capacity that they'd had before. In 2018, this past year, we started the Suicide Risk Management Consultation Program, which is for non-VA healthcare professionals who can call in and ask, hey, help me through this issue, help me through this situation with my patient or with my loved one, with whoever it might be of concern. Further, in 2018, the VA partnered with SAMHSA in helping to declare the Mayor's Challenge. Some of you that are in some of these cities we can talk about a little bit later might be included in this. And then also more recently, you've likely heard this just by watching the evening news, the White House issued an executive order called Supporting Our Veterans During Their Transition from Uniform Service to Civilian Life, which very specifically instructed the VA, the Department of Defense, and the Department of Homeland Security to support transitioning service members by providing access to mental health treatment and suicide prevention resources with an emphasis on the critical 1-year period following discharge, in many ways, regardless of form of discharge. We also better understand veteran risk factors for suicide. The more frequent deployments have been to hostile environments, and the longer those deployments have occurred, the higher one's risk for suicide, the higher one's rate of suicidality. Exposure to physical or sexual assault while in the service, and I can't stress this enough that it's not just limited to women, and one's furtherance of service-related injury, service connectedness, service disability. The way that we know, back up a little bit, pardon me, the more that we know that somebody is further and further impacted in their civilian life by an injury that occurred, whether it be physically or mentally during service, the higher the rate of suicide. And if you think about this, all of these are identifications of exposure to extreme stress, which we know is certainly from the civilian world and the civilian data. Exposure to extreme stress certainly raises one's risk for suicide. The current state of affairs for suicide prevention, what are we doing about it? What's the VA doing about it? Well, again, we've made it our top, and I can't stress this enough, our top national clinical priority. We've made suicide prevention quite literally everyone's business. Continuing to fund national programs to filter down to network level and local facilities, lead the development of innovation and programming for suicide prevention strategies. We're talking different, we're talking more openly, and I hope that this is a part of that for you. We're more extensively and intimately engaging veterans and their families. And if I dare may say, and this is talking from being here, sitting in this chair, we are finally getting out from behind our VA walls and engaging with the community at large. No longer are we just the big brother up on top of the hill. So let me gloat a little bit about our Kansas City VA here. Much of the blue in the middle is where we serve. Apologies again to those folks in Eastern Kansas that I'm pulling over, because you all do a wonderful service to those that are in the Eastern Kansas part of this. But this is where the Kansas City VA is, spread out in a variety of different areas throughout this complex network of the Heartland, with many different facilities serving more than 48,000 veterans and a mobile medical unit that is entirely, sometimes too busy, but proud to take the VA to wherever folks are. Again, gloating a little bit more on the mental health service at the Kansas City VA, we structured our care in a reoriented or recovery-oriented model. Certainly one that's evidence-based with a de-escalating or an escalating levels of care, all the way from basis of primary PCMHI, primary care mental health integration, up to acute inpatient care. But slowly, not slowly, quickly, de-escalating level of intervention and level of external safety, external control, to allow people to get back to their quality of life the way that they choose to lead it in a safe manner. You have to refer to the PDF again for this, maybe next slide. Briefly, what the Kansas City VA mental health services offer, everything from homeless support services to transitional work compensation type places, and the traditional type service of mental health clinic, mental health intensive case management, substance abuse treatment and rehabilitation for such things. really a wide array that is quite significantly based on evidence-based practices and best evidence here. And maybe more at large, but specifically here at the Kansas City VA, KCVA, not KV, sorry guys. Here's what Suicide Prevention Coordination is doing. We have one person designated as the SPC, and then here 3 Suicide Prevention Care Managers. But every VA that you're at, and every VA that your community has, if you're not at the VA, has these folks a part of it. More than 400 suicide prevention focused people nationwide, providing absolute identification of veterans who are at high risk for suicide, consultation within the hospital and outside the hospital, and I can't stress that enough. If you have access to them, make them a part of your consultative process, especially if you're outside the VA. Responding to veterans crisis line consults, providing community outreach, and then training just all over the place. Team responsibilities are innumerable. Sometimes the the day feels like it never ends, and I know that probably feels that way for a lot of you. But I promise that these days are full in suicide prevention land, because we're tracking and reporting on veterans that have a flag placed on their chart, ensuring that they're getting good follow-up care in that acute risk period following the flagging. We are tracking and trying to coordinate suicide-related behaviors within the entire hospitals, responding to veterans crisis line referrals, offering as much consultation to both VA and non-VA providers as we can, and then trying to really establish ourselves as the experts in community-based best practice for suicide prevention and collaborating with partners as we talk about moving forward. And then as well, seeing us out in the community, attending a variety of events, anywhere from meeting with local veteran service organizations to, I was at the Royals game a few months back before it got cold, but wherever we can possibly be with veterans or with families of veterans or active service members who are about to transition out, I want to be there, we want to be there. We also, at the VA, have a new national suicide risk identification strategy. And this is our big talk for how we're going to better standardize and across the board assess for suicidality. Because this is no longer being recognized as, or we won't allow it to any longer be recognized as just a mental health condition. This is a human condition, and it's evident in a variety of areas. And as a holistic whole health facility, we need to be better at identifying risk of suicide wherever we see patients, wherever we see veterans. And we're doing this by a stepwise process, from the item 9 of the PHQ 9 being added to a number of different screens already, that if things are positive, we move it on to a secondary screen, the Columbia screen that many of you might be familiar with. And if that's positive, we move it into a much more comprehensive evaluation and all of these has to be done on a pretty timely basis, a very coordinated basis that takes a whole lot of different folks to be a part of this good clinical care. We have a new national safety plan. The second page of this came up, sorry, the first page, but what this really is, it's a great tool. And if you actually need a copy of it, we can certainly give that to you and I can send it on to you. But what this is to help sit down with a veteran or patient about what really matters to them, what really is going to work for them in a particularly tough time. Identifying what their triggers and risk factors are, what they can do about it by themselves if they're in a tough spot, and then where people that they can rely on and social settings that they can go to that can help provide distraction or be a part of their relaxation, as well as who are their family members, friends that they can reach out to, and professionals, agencies who they can contact to help. One of the more particular parts about this is on that second page, as you see on the right here, is our renewed emphasis on what can we do as healthcare providers to help that person make their environment at home safer. So we're talking lethal means restriction, with a huge emphasis on firearm safety, with a huge emphasis on opioid risk safety. And the good news is, there is good news in this, I promise, the VA is actually having an effect. But I can tell you, it's only on the veterans that are coming into our services. If you look at the different columns on the right-hand side, those that are coming into our services have a lower risk of suicide than those who are not coming into our services. And did you know that more than 50% of all veterans, quote-unquote veterans, do not even use their VA benefits, and they do not access the VA healthcare? So from my role, and what I try to stress to everybody around me, including my director and chief of staff and everybody that helps to make decisions around here, we have to go get those that are outside of our walls, those that are in our community, and those that are seeking care through partner institutions. Because we just haven't done enough yet. The stability of this number is troubling to me. And not only the stability, but the gentle increase as we go along. All right, so here's my own little, this is as much as I trained in visual arts and in computer-aided design, but my very simplistic, but I think fairly spot-on representation of what, unfortunately, I think much of our efforts that I just described to you, and my position is boiling down to. We identify veterans, and we identify veterans very well. And the VA clinicians in the room can help reinforce that we identify them very well with risk assessments and increased screenings and monitoring and honestly just knowing our veterans better than most other whole health providing facilities can. And we are there with them when a suicidal crisis hits. We flag them, we monitor them, we open our doors even wider to VA mental health services, and we're constantly evaluating their ongoing risk level and monitoring their well-being. But I can tell you that we're missing something. We're missing the life before the boom. We're missing the opportunities to have a substantial impact for all veterans before this crisis hits. And some would dare to even say that we have more of a suicide reaction program. So my challenge to you today, and my challenge to myself on a daily basis, is that where do we fit in here? Where do you fit in here? Where does the work that you do have an impact? Does your VA know about it? And does the big VA know about it? Do the veterans accessing care at the VA know about it? Do the veterans not accessing care know about it? I want you to think about this today and afterwards. Know where you fit. And don't leave here, please, without knowing where you fit. And ask, plead, beg that others know about it. Maybe we can start having an effect. Too much of a gap in that crisis, or the before crisis. So where are we headed? Well, we're headed upstream. 286 new suicide prevention case managers and coordinators. We're changing coordinators' roles from being clinically based, and I can tell you it feels awfully clinically based, to more so attending to this community broad-based upstream approach, which extends beyond just the healthcare setting to truly help to prevent suicidal thoughts and behaviors. We're training these team members in public health models of suicide prevention with more extensive tools, trying to standardize and expand this coordinator role, implement a staffing model and staffing resources to help meet the ongoing needs of at-risk veterans, and not only just responding to those that are at risk in that acute risk period, but again, trying to get to them before they reach that crisis hit. Because if we've gotten that far, we've missed opportunities. Providing public training on the public health model, and creating an enhanced set of tools for these upstream approaches. Community outreach, trying to standardize assessments and cross-facility assessments, and then getting good, timely data. All right. So the National Strategy to Preventing Veteran Suicide, the updated version. What has 2018 been all about? Here's our overarching goals. Expanding the focus of the prevention initiative with this public health approach, working, I think, finally, for the better with the Department of Defense and community partners to intervene with veterans just transitioning from service. Increasing this idea of seamless access to mental health care, engaging veterans better in this measurement-based care that's backed by comprehensive data, and again, engaging upstream before the crisis actually hits for them. Now, I had a video. I'm not sure if it will actually work, and if I destroy our connection, I'll count it as a rookie mistake. But if not, actually, so it's not going to show. Please watch this video if you don't mind. Very brief, 2 minutes long. I think it's really inspiring not only for oneself, but also for those around you. Think about where you fit in and where this can be a part of things for you. So what's the future of suicide prevention here at the VA? It's a national strategy. We don't do anything around here without it being written down and guiding us forward, that's for sure. There's a focus here on healthy and empowered veterans, their families in particular, and the communities at large. We work with community partners, policymakers to help promote resources for veterans, and to promote mental health awareness and treatment. And I, above all, try to stress, especially the community partners, that the VA can't be the ones that we can't take this all the way. We have to use community partners. We have to use these relationships that we have with one another, these partnerships that we can build going forward. From a clinical and community preventive perspective, using resources, training opportunities, interventions, and particularly lethal means safety resources with providers outside the VA. And then also reaching out to and embracing, finally, I think, with clergy, first responders, law enforcement, other community partners that you might be a part of. Focusing on working with local EDs and hospitals to promote veteran suicide prevention resources, identifying those that are out in the community that do have a veteran or military service background, that they are veterans, and that with that description they carry a particular risk, and informing community providers of that. And then sharing this data, sharing what we know, and being as open and honest about nationally what is going on with our veterans, what is going on with our service members, what are the numbers, and how can we best strategize to complete this together. So the public health approach to suicide prevention looks like this. Starts with the problem. Where does this problem begin? How could we prevent it from occurring in the first place? And to answer this question, we have to use this public health model, using a systematic, scientific method for understanding and preventing self-directed violence. And remembering that over 50% of veterans do not actually use the VA for services. We're never going to be able to pull them all in. So how can the VA better inform the community where they are actually getting care? We're going to do it in a tiered, stepwise manner. Here's the developing strategy for suicide prevention in the VA. Starting with the indicated, because we have worked up from there and are continuing to work upstream. Referring more and informing more of the Veterans Crisis Line. That's the biggest access point at time of crisis, in helping to delay suicidal behaviors by focusing on at-risk veterans and means restriction, and expediting care for those that are identified as high risk. The selective approach in the middle utilizes the targeting of specific groups, like female veterans or those who identify with the LGBT community. We're training all of our staff, from environmental management to new surgeons to shuttle drivers even. Can't tell you how many shuttle drivers hear so much stories. They're so rich of stories, so many stories on a regular basis just by driving folks in from the parking lot. And we've beefed up our availability of mental health services for those veterans newly transitioning. Quite literally, suicide prevention is everyone's responsibility here. And the universal component, moving all the way upstream. I'm here to tell you, and I think it's the most important one, that this is the public awareness, the educational campaign. We're not reaching the veterans who are coming through the VA at a quick enough pace. So we want to help inform the community, help inform the veterans, help inform their loved ones, the communities that they exist in, wherever they are, talking openly about suicide and in responsible, caring manners, and working to restrict hotspots for suicide as well. So what does this new role look like for suicide prevention coordinators? What does public health look like for those that have been pushed to providing the clinical care of those that are most at risk? Well, currently, we work with veterans in the care who are at risk for suicide or who have attempted suicide. Again, that crisis has occurred. We're aware of the crisis. We try to address it in its acuity then. We need to go back upstream, implementing this broad-based upstream approach that's not just their healthcare, but working to really prevent suicidal thoughts and behaviors that nearly always occur before behaviors or before attempts occur. And the idea is that suicide prevention coordinators are uniquely positioned to advance this approach for the VA and to better pull in not only the VA and its facility and those that work under it, but also the community at large, where we're connecting facilities, we're connecting partnerships to help veterans before they reach this crisis point. Suicide Prevention 2.0 is what we've identified through our new director as the way forward. The goal is to standardize this SPC role and teams across the VA, and enhancing the consistency of programming across communities. That we're really, again, not just this big building up on the hill, that we are out from behind our walls. We're finally, if I can say it informally, playing nicely with others. That we're not just the one place that can help facilitate the needs of veterans, but that we really are just a partner in all of this and willing to do whatever we possibly can to help veterans and help humans at the same time. So hiring to meet some growing need, redistributing workloads to other roles, delivering more comprehensive training on this public health approach, coming together with new resources and different tools, and then helping to provide this technical assistance about how we can address this public health approach. The Mayor's Challenge, if anybody is involved in the Mayor's Challenge or knows of the Mayor's Challenge, or take a look at the map, and this is where the Mayor's Challenge is currently ongoing. It's this partnership between the VA and Health and Human Services, the SAMHSA organization, to eliminate suicide using this comprehensive public health approach to suicide prevention. These teams are not VA-led. They are community-led, and VA is a partner in it, collaboratively pulling together groups of community, municipal, military, law enforcement, all kinds of different stakeholders, providing technical assistance to support local efforts and to document outcomes. I can tell you here in Kansas City, and those that are part of the Kansas City news, if you read it all, the mayor of Kansas City has really taken on this. And I say Mayor's Challenge because that's what it's been identified as. But it takes one single person who represents or who is that mayor to really push this agenda forward. And Mayor Sly James here in town has, not just because he's a veteran himself, but because he cares about this mission, has really owned this process and pushed this forward and made this well known to his community how important this is to him and how important this is to everybody, as it should be moving forward. Participating cities in this task work again with military, civilian leadership, developing strategic action plans to reduce suicide behaviors at local levels. It necessitates acquiring a familiarity with issues surrounding suicide prevention, and specifically those who have served along with their families. Increasing knowledge about what faces us, what the challenges have been, and what lessons we've learned thus far, what the best practices are and how to deploy them, how to prevent, reduce suicide, and to in turn evaluate program outcomes. And to kind of wrap up all of this, if you are interested in this, or if this is something that's moving forward, or you are a community partner that could benefit from tagging on with the VA, well, here is a perfect example of what a memorandum of understanding with your VA might look like. To identify what's the partnership going to do, and what are the individual partners going to do? Where will the technical expertise best be applied? Who's responsible for these parts of the initiative? And what's the structure of the organization? And who's making decisions in the partnership? So in my final thoughts, at least in this part, is that we know we can't do this alone. It's these partnerships, it's partnerships with you, it's partnerships with those that you know, which might finally start to have the intended impact of reducing that 20.6 every single day. So my challenge to you is, where do you fit? All right, I have, after some questions here, some resources, so we can go through that here in a little bit. But let me take a look back through the chat box about what might have come through. And again, thank you all for paying attention. I appreciate it. And if you have any questions moving forward, please let me know as well. Hello, San Antonio, UT Health. You all are surrounded, that's for sure. Police and public safety psychologists. Many thanks to you, Jocelyn. All right, sorry about again the presentation. Everything didn't get loaded technically. So question for later, how many of the 20.6 veteran suicides are veterans who had contact with VA services? An excellent question. Unfortunately, we know that data. It's between 12 and 14 of that 20 have never been to the VA, have not been to the VA. We talked about it a little bit, but there's a specific number. And so I stress this number to the patients, to the veterans that I see in my substance abuse rehabilitation group, because there's about 20 of them, and sometimes it's a pretty rowdy group, but I can say to them, I said, look around, there are 20 of you sitting in this room, 20 of your brothers and sisters. This entire population, every single day, we lose this number. And so many of them have not been to the VA. And so I say to them, you know, I'm not necessarily here to talk about your experience with suicidality, but if I can put these things in your head, if I can get you talking about this and thinking about your own experience, you might be better aware for those that you're around. Because I know that when you leave here, you're going to go back to your community, you're going to go back to your partnerships, you're going to go back to your groups, whether they are positive for you or not, and you're probably going to know other veterans. So be aware what they're going through. And if they haven't gotten to the VA, or if they haven't accepted kind of their veteran status of things, or even just their idea that things are different because of their identification as being a veteran, talk with them about this. Talk with them about why their risks are so critical and what you might be able to do about it, for sure. Because again, as we show, the data says that if we can get them into the VA, into that specific guided focused treatment that appreciates the most out of all partners their veteran status, then we can do something about it and do it in a better way. All right, question. Research is showing that thoughts on the suicidal spectrum, morbid rumination to active planning, are far more common than not. Probably I couldn't agree more. Is it therapeutic or even reasonable to tell vets and their providers that they should be able to stop suicidal thoughts? Or maybe better to focus on active, proactive coping with those thoughts? Excellent question, Erica. I really appreciate it. And putting me on the spot, but hopefully I can address this with my initial thoughts. Without slamming the door on the idea of wherever it fits in intervention about, hey, you should stop having suicidal thoughts, I think that from a existential understanding of just kind of human experience in general, I mean, we all have questions about our demise, what it's going to look like, and what distress and what difficult and crisis times in life have an impact on that. So you're right. I mean, I think so many people, and probably the majority of us, and if you want to just blanket it, that we all kind of are on the spectrum of mortality, right? And how much we think about it and how much our own behaviors contribute to that mortality. So when I talk about suicide with my folks, I talk about it as a tool. I talk about suicide as a tool in somebody's toolbox. I talk about it as a tool just like medication is a tool, just like therapy is a tool, or mindfulness, or just like meth is a tool, or cocaine, or alcohol, or whatever it might be. These are all tools of getting through or of utilizing in a particular situation. The problem with suicide is that it's the most consequential and the one we can't come back from. So I think if you talk about it in this manner of it's a tool in somebody's toolbox, sometimes, and I think probably for the most part, those that resort to experiencing suicide or suicide attempt have felt that it's the only tool that's left for the job. That nothing else is working. None of those supports, none of those substances, either the positive or negative behaviors, nothing else is working. That this is the most appropriate tool. That we can normalize some of those behaviors. Normalize some of those thoughts especially. We can identify it as a tool, put it in the realm of everything else, weigh it in its pros and cons and its consequences, and really get to this idea of we don't have to choose this tool. And at the same time we put distance between this tool and you, we can put other tools in your toolbox. We can have effect by going against this stopping of things, or the stopping instruction, and saying, hey, it's all right where you are. We get it where you are. And many other people are right there too on this spectrum. What more can we do? What different can we do? Because there's a finality to this tool that we just can't come back from. And other tools might really be better for the job, for sure. Thanks, Erica. Well, while some other questions are coming through, let me throw you some resources. Some of the links might not pull up, but I certainly want to share them with you. I was wondering more about stopping SI as a goal of the programs you discussed. I think, how about this? The big civilian effort out of Detroit, I think it's Detroit, right? It's Michigan for sure, is Zero Suicide, right? That's the name of the program, right? Zero Suicide. With the understanding that that's not likely to be possible. We're never going to get to zero. I think we have to face that unfortunate fact. So maybe in the same vein, we can understand that to say, hey, we're not going to stop suicidal thoughts. And I think with knowing that, with appreciating that, with normalizing it, we don't have to focus on that, while at the same time we'd love for that to be the goal that we're always going to achieve. Just like zero suicides, we're always reaching for that goal. We're never going to stop this. So let's work in that middle. Let's work to a better outcome, and allow people to be where they are and work with them with what they're experiencing. All right, so for those in the VA, some TMS trainings. I know you love them. Love them all year long, but there are some additional ones: SAVE training and the online refresher course. That was loud, sorry. For those that are within the VA and outside the VA, there is a risk management consultation program run out of Denver, out of the VISN 19 MyRec. And really give these folks an email, give them a shout, search for this hashtag, you can help, or you can reach out to other professionals and help you as a professional care for your patients, care for your veterans, care for your loved ones, anybody that you have in contact with that you might have concern about the suicidal risk that they're presenting with. Veteran clinician outreach here. This is the Make the Connection resource, and it's really kind of a detailed and intimate experience with what veterans are experiencing on a regular basis, or what many veterans have experienced, given their recovery-oriented care, particularly some from suicidality, for sure. And a really powerful resource for veterans and patients to relate one-on-one. Here's the Community Outreach Toolkit. You can find this on the go.usa.gov website. Facts and myths about suicide, how to talk about suicide, what we can do from a community-based standpoint, where you can really step off to making a difference in your community and helping to make these public and private partnerships a reality. The psycharmor.org website is really beneficial, and not only from a provider basis, but just from a community basis, and what it's like to be a veteran, and what military service members, what veterans would love for you to know about them from a generalistic and overarching manner, but what really helps to characterize this group of folks. And then firearm and safety outreach. What can we really do to help with these lethal means restriction type activities? How can we best help to make their environment a bit safer? And how can we help to motivate, especially when it gets to the touchy subject of firearm and firearm. What's the word I'm looking for? We'll just say Second Amendment, okay? And how we can help navigate these sensitive conversations about, hey, we think this is a good idea. Let's make it temporary without restricting your rights. But how do we keep you safe? And please, as much as you can, maybe one of the more specific resources at the end is where and how can you be there for a veteran? This brand new campaign, #BeThere. You all might have heard about it. Tom Hanks did the introductory promo video. But how can we all be there for veterans? All right. And lastly, here's me. So if you haven't known me before today, here I am. I'm happy to meet you. Thank you for being on board. I appreciate it. Please know me. Please know me, and please let's work together. If it's not me, then use somebody that's in my current role around you. We want your ideas. We want to share your successes, recognize where you can have an impact, whether you're with the VA or whether you're outside the VA. I want to share your good news with those that are wearing VA badges, those who influence our decisions. Call me, email me, please bother me at home, whatever it might be. Just be a part of our moving forward and helping to reduce that 20.6. Okay. Thank you very much. I will go back through this little chat box here, but I appreciate everybody's attendance and non-verbal, non-intrusive conversation. And Happy New Year, everybody. All right, the link to VA disability. VA's negative reputation with non-VHA veterans, which contributes to their reluctance to come to us. We also see many people who have had prolonged and multiple deployments, which are now recognized as serious suicide risk, be denied service connection time and time again. Is there any movement to begin dialogue, training, partnership with our VBA colleagues who often trigger a boom crisis? Very well said. Before we can get to the veteran, so here, no doubt about it, that many folks are struggling within the service connection with the disability benefits process. You know, I think I've talked till I'm blue in the face, I think, sometimes about the two sides of the VA, one being the healthcare side, the other being the benefit side, but the community doesn't care, right? Veterans don't necessarily care. They know the VA, and so we're all a part of the VA. So we're all affecting each other. I can tell you that the movement is beginning. The dialogue is beginning. I think it has to go so much further. And while they're working on their side, one of the initial partnerships that I know of is the fairly new, within the last few months, ability for the benefit side to really look at the financial, and this is coming from a debt standpoint. But if there are debts to a veteran who has been identified as high risk for suicide for a variety of reasons, the VBA can help to address that from a lessening of a financial debt to a forgiveness about it. I have mixed feelings about it. I think probably because if you look at hindsight, you know, it might start to be one of these financial gain parts about it, but that's another conversation for another time. But at least there's partnership, right? So we're moving forward. But no doubt about it that a majority of folks I would say I talk to on a regular basis are somewhere in this process of compensation claim, appeal, uh, years prior of not being recognized or feeling like they haven't been recognized. So, and maybe that leads me to my most important part. My most important part. The V of that Operation Save training is the validation part. And sometimes that can be the most important but often overlooked part. And that if we really can get it about what that person is experiencing, and as a part of that, their significant sometimes frustration with this part of the VA, which we represent, then I think we can go a long way in clinically helping to appreciate this, and clinically helping to identify these symptoms and to talk through this with them, advocating for them as best as we possibly can, and helping them to come to their own resolution of things that they can and can't control. Because I know I often feel stuck about my opinion on somebody's service connection or history or recognition even of what's going on. But me one-on-one with somebody, I can start that recognition process. And I can be a part of that moving forward, to where somebody else 1,000 miles away making a decision may never hear about this. I can start to have an impact with that veteran. And we have a start there. Like, we can build a relationship, we can build a rapport, we can build mutual advocacy starting at that point. Thanks, Mary. It's a frustrating topic, that's for sure, and I'm glad I'm not the only one that's experienced, and I know that I'm not. All right, thanks everybody. If anybody else has any questions, I'm happy to stay on for a little bit longer, but again, Happy New Year. Glad to have you along. I hope that this isn't the last time that I hear from you, but please, I'd love to hear from you
Thank
if
you,
I can do
Dr.
anything or if
Parrott.
we
And
can
before
point you
people
in the
go,
right direction or
I
whatever it
just
might
want
be.
to again
So take
thank you
care,
guys
everyone.
for the great questions. I've learned a lot, and it's kind of made me start thinking about maybe some untapped resources, kind of thinking in our community, like you mentioned, the shuttle drivers, and maybe what I can do to also help spread the word, beyond just the clinicians, as well. Um, and so I wanted to just wrap up with some logistical things. So for those of you who are interested in receiving a continuing education credit, you can do so by completing the online evaluation. You'll see that there's a link in the note box, and I think I can also type it into the chat box if that makes it easier for you. Hopefully you can find it there. And then, so for Division 18 members, of course, continuing education credit is free. For people who are not members but still would like credit, we now have the option to allow that through a $15 payment through our PayPal. So that's also the link to the PayPal for those of you who are not members but wanting continuing education. There's a link also through on the note uh, pod. I'll send a follow-up email to everybody who registered for the webinar today, so that way you have it all written out too. But if you want to go ahead and take care of the survey, do so now. And also just want to let you know too, next month's webinar will be held on Thursday, February 7th, same time as this one. And it'll be Dr. John Klosek, who's our National Mental Health Technical Assistant Specialist. He'll be sharing with us how we can satisfy our inner researcher through clinical process improvement. So more details to come, so stay tuned. And for any other follow-up questions, please feel free to contact me. Thank you all for attending today. And thanks again to Dr. Parrott. Really good presentation.